medical student, and today I'll be explaining ECG to you, as well as arrhythmias. It is a pretty heavy topic, but inshallah, it's going to be easy and all understandable. So here are the main objectives for what we're going to be doing today. So we're going to start with what is an ECG and how exactly does it work, the electrical basis of the ECG, an introduction to the vectorial analysis, normal ECG fundamentals, as well as major arrhythmias and identification. So this is just the main topics. There's a lot of subtopics, and we're going to cover all of them, inshallah. Now, what is an ECG? So an ECG, or an electrocardiogram, is basically, let's break the word down. So electro means electrical activity, cardio stands for heart, and gram means record. So let's put them all together. So it's a recording of the heart's electrical activity at the body surface by electrodes on your chest and limbs. So you place these electrodes on your body's surface directly on the chest and the limbs. Where do the electrical impulses start from? They start at the SA node. Can someone tell me where the SA node is located? Anyone? Yes, in the right atrium. Perfect. So it starts from the right atrium, but now there is a conduction pathway. So it goes from this SA node in the right atrium, it goes to the atrial muscles, then the AV node, then the bundle of His, then the left and right bundle branches, the Purkinje fibers, and finally the ventricular cardiomyocytes. This is the whole conduction pathway. Now, how is an ECG recorded? So how are we getting the measurements, basically? What is happening? So what the ECG does, it records potential differences on the body surfaces that are caused by the heart's electrical activity. Basically, let's say you have an electrode here and an electrode here, and this is a positive one, and this is a negative, and you have a voltmeter in between. This potential difference between this point and this point is what's going to be recorded by the ECG. Now, electrodes are sensors that you place directly on the skin, as shown here, like these ones. These are all your electrodes. Now, what is a lead? A lead is not an electrode. It is basically a combination of two electrodes forming a circuit to measure the potential difference. So it makes sense. You need more than one electrode to kind of calculate the potential difference. And we have 12 leads in our normal ECG, and each lead gives us a unique view of the heart. So let's start with our leads. So we have our standard limb leads, or our bipolar leads. Why are they called bipolar leads? Because you place them on two of your limbs. So they're going to record the voltages between two limbs. We have lead 1, lead 2, and lead 3. So lead 1, which is the first one, is going to be placed on your right arm, is the positive electrode. I'm sorry, no. On your right arm is going to be the negative electrode, and it's going to go towards your left arm, which is going to be your positive. This is how it's going to be placed in your body. So from your right arm to the left arm. Then we have our lead 2. The lead 2 negative electrode is also placed on the right arm, and the positive electrode is placed on the left leg. So this is your lead 2. Now we have our lead 3, which is placed on the left arm, which is our negative. Unlike the lead 1, where the left arm is our positive, here the left arm is our negative. And it's going to go to the left leg, which is our positive electrode. And this is going to go downwards. The arrow is always going to point towards the positive side. Now, can you see this form like a triangle here? This is called the Itowen's triangle. We make this, it's an imaginary triangle, and we make it around the heart to kind of use it for this law. So what the law says is that lead 2 is equal to lead 1 plus lead 3. What that means, if you notice here, if you look at the amplitudes here, and for lead 1 and lead 3, you can kind of tell that lead 2 is a sum of both of them. Stop working. Okay, so it's basically, you need to remember that lead 2 is equal to lead 1 plus lead 3. Yes, does the right hand get the positive? I'm sorry, what? The question. Just a quick recap for whoever asked the question. Lead 1, the negative electrode is in the right arm, and it's going to go to the left arm, which is the positive. Lead 2, right arm is the negative electrode going to the left leg, which is positive. And lead 3, left arm is the negative going to the left leg. Left arm is the negative going to the left leg, which is positive. You just need to memorize all of these. Now, let's talk about our unipolar leads. Let's start with the augmented leads. Can you repeat? Okay, perfect. think it's a bit confusing, so let's just use our diagram. So we have, let's start with our lead one. Lead one, the negative electrode is in the right arm and it goes towards the left arm where you have your positive. This is for lead one. Lead two, the negative electrode is placed at the right arm and it goes towards the left leg where it is the positive. So wherever the positive is, the arrowhead is going to point that side. For lead three, the negative electrode is at the left arm and the positive electrode is at the left leg. So the arrow is going to go from the left arm to the left leg. Is that clear now? You just need to memorize this, and the basic principle you need to remember is that lead two is equal to lead one plus lead three. So the sum of this and this will give you this. Okay, now we come to our augmented limbs, which is the unipolar. So these are also frontal plane views. So as our bipolar leads, they were also giving us a frontal plane view. This is also giving us additional frontal plane views. Now for this, unlike the first one where we had two electrodes that we're placing, here we have an exploring positive electrode, and there's going to be a paired central reference electrode. This electrode is going to be, you can say like an average of both the others. So let's say if your electrode is placed at the right arm, the reference one is going to be an average of the left arm and left foot. So the average of the other two. Let's start with the first one, which is AVR. AVR, the positive electrode, where is it going to be placed? The right arm. AVL, it's going to be placed the left arm, and AVF will be placed in the left foot. So an easy way to memorize this, AVR, R stands for right arm. AVL, left arm. F, foot, so left foot. Now, if you notice, all of them are positive, like AVL is positive, AVF is positive. Why is AVR negative? This is because it views the heart from the right shoulder, and the overall depolarization will move away from that direction and down and to the left. Hence, you're going to see it's going to be a downwards reflection. Okay? Let's move on to our last 6 leads, which are the precordial or chest leads. These are also unipolar. Unlike the first two, which give us a frontal view, this one, you're going to look at a horizontal plane of view. So you're looking at the heart from the front, from the side, and from in between. We have V1 and V2, which will give you a right ventricular view. We have V3 and V4, which will give you a septal view, so at the septum of the heart. V5 and V6, which will give you a left ventricular view. So it's going to be placed like this directly on the patient's chest. And these are done on the ECG shown. Now, this is all 12 leads together, and this is how a normal ECG strip will look like. As you can see, it's like a 3D view of the heart. You can see the frontal plane, you can see the horizontal plane, everything is seen in the ECG strip. Normally, when we look at a normal ECG waves, we look at lead 2. So all the QRS and all of those we're going to do, it's going to be from a lead 2. Now, a quick checkpoint. When a recording lead 2 on an ECG, the right arm is negative electrode and the positive electrode is where? Anyone? Yes, perfect. That electrode is going to be on the left leg. You can draw the triangle for an easy understanding during the exam. So you can basically draw the whole triangle and solve it, but it's also easy to just memorize. Second question. When recording lead AVL on an ECG, which is the positive electrode? Yes, it's the left arm, perfect. So as I said, L just connected to left arm. Perfect. Let's start with action potentials. Why are we doing action potentials here? We're going to correlate them on how we see them on an ECG. So the two main action potentials are the SA node cell action potentials and the ventricular myocyte action potential. For the SA node, you're going to see the main function is pacemaking. It does not have a stable resting potential. So as you can see, the resting potential is not stable at all. There is a slow depolarization. Why? Because of the calcium channels. It's the L-type calcium channels. There is also no plateau phase. For the ventricular myocyte, the main function is contraction. They have a stable resting potential. There is fast depolarization due to voltage-gated sodium channels, and it does have a plateau phase. Now, The SA node cell, it initiates the P wave on the ECG, and the ventricular myocyte, it creates the QRS and T waves on the ECG. We're going to see it here. So we have our P wave. If you draw it here, connected, it's the atrial cell depolarization that is coming. For the QRS complex, if you go here, you're going to see it's the ventricular depolarization. And the T wave here is going to be your repolarization of the ventricular cell. So this is how you're going to see that the action potentials are being shown in the ECG. The SA node, it's going to initiate the P wave formation, but it's not, P wave is not the SA node's depolarization. It's the depolarization of the atrial cells. Now, quickly, we're going to talk about the cardiac conduction system. We did mention that there's a pathway that the system follows. So from the SA nodes to the atrials and the AV nodes, this is different from the conduction system. So this conduction system is the speed of conduction. Where does it go the fastest and where is it slower? So the fastest is the Purkinje, then the atria, then the ventriculars, and the AV node. This is just some values. You don't really need to memorize them. It's just to kind of understand. So you can see ventricular, the Purkinje fibers are 4. And after that, we have the atrial, which is 1. And then ventricular 0.5 and AV node is 0.05. So you can tell how it's decreasing. You need to keep this in mind as we're going to be visiting topics that are going to refer to this throughout this PPT. Now, how do we measure ECG? What's actually happening? What's coming in the voltmeter? So depolarization is the spread of action potential between the cardiac cells through their gap junctions. So from here to here, it's going to jump through the gap junctions. It's going to create tiny extracellular currents as it moves through, and it's going to be recorded in the voltmeter. It's going to be a sum of all the electrical activity. At rest, when there is no potential difference, so as you can see here and here, there is literally no potential difference. It's the same thing. So you're going to have no potential difference. So on the ECG, it's going to show up as a straight line. It's going to be the isoelectric point of your ECG. When we have depolarization, you can see that the wave of depolarization is traveling from the left side to the right side, and a potential difference appears. So the charges are changing, right? The depolarization is happening. As a result, what's going to happen, there's going to be a deflection in the voltmeter. And since it's moving towards the positive electrode, we're going to have a positive deflection, and it's going to show in the ECG as an upward deflection. Once the entire region is depolarized, so all of it changed to depolarization, it's going to return back to the isoelectric point. Is that clear, everyone? Yes, we can move on. Okay. Now, an important thing we need to know before we move into the details is the heart's electrical vector. So the heart has a cardiac axis. Now, a vector is a quantity with a magnitude and a direction. So it represents the electrical activity. The resultant vector here is the sum of all the small electrical currents in the heart. So the electric currents here and here and here, everywhere, the sum is going to be this big vector. The base of the heart is relatively negative. So negative here, and this will be positive. This is the way the vector is going to be pointed. It's downward and it's tilted towards the left side. Now, something to remember when it comes to vector is that the vector points always towards the positive. So the arrowhead is always going to be towards the positive area, and the length of your vector correlates to the amplitude of the voltage that you're going to see in the ECG. So let's say you have a small arrow and you have a big arrow. This one, you're going to have a smaller amplitude, and for this one, you're going to have a bigger amplitude. And if it's in the reverse direction, it's going to show as an upside down or a negative deflection if it goes against. Now, projection. So we don't directly see this cardiac, like vector directly on the C. What we see is the projection of each of the leads axis. So basically, let's say we're just going to take one of the leads here. We have lead 1 here. This is our cardiac axis. You're not going to see this in the ECG. You're going to see this one. You're going to make a perpendicular line, and you're going to make an arrow. So you see this arrow is the thing that you're going to see in the ECG. It points towards the positive direction, so it's going to be a positive deflection. And you're going to do this for all of them. So let's say this is your cardiac vector. You have lead 1, so you're going to draw a perpendicular line to lead 1. This arrow, as you can see, also has a small magnitude. Like the length is small, so the magnitude will be smaller. This one, however, if you make a perpendicular line, it's a longer arrow, so the amplitude is also going to be bigger. You continue to make the perpendicular line. This one is a normal sized, so you're going to see a normal. So this determines both the direction. Is it going to be a positive deflection or a negative deflection, as well as the amplitude. Now, a basic rule is that if the vector projects on the positive side of the lead, the positive deflection on the ECG. And if the vector projects onto the negative side, how does it determine the deflection? Okay. Let's say, let me just erase this for you. Okay. Let's say if our arrow was more something like this, and you, instead of our cardiac axis being here, it's something here. Our mean axis is here, and you're gonna join the perpendicular lines, and you join it here to your, oh, wait, sorry about that. 1 second. You join it here, the arrow is going to point towards the negative. If it points towards the negative, you're going to have a negative deflection, which means you're going to have a downward wave on your ECG. Does that make sense? Okay. Now we're going to start by drawing the ECG step by step so that we know what each segment is, all the fundamentals, everything about it. So the first thing in the ECG is our P wave. What does the P wave represent? It represents atrial depolarization. So it's the spread of electrical activity from the SA node through both the atria. The normal duration you need to know is 0.08 to 0.1 seconds. And it's always the first deflection in a normal cardiac cycle. Why is that so? Anyone? Okay, because your cardiac cycle is always going to start with atrial depolarization, hence it should be the first thing you see on the ECG. Yes, SA node starts, perfect. Now, if it's absent or abnormal P waves, it's going to indicate that there's a problem either in the atrial depolarization or the pacemaker origin, so something in the SA node. Now, let's continue. What comes after the P wave? We have the QRS complex. Okay. Yes, there's going to be a delay. The segment here, there's going to be a delay. The AV node delay. Yes. We're going to discuss that when we talk about segments. For now, we're just talking about the main components. So the QRS complex consists of the Q wave. So this whole thing is the Q wave from the isoelectric. This whole downward deflection is a Q wave. Then we have the R wave, this part. And then finally, we have our S wave, this part. So it consists of 3 waves. So the first negative deflection before the R wave is Q. The first positive deflection is the R, and the negative deflection after R is your S wave. And together it forms a QRS complex. The normal duration is 0.08 to 0.1. It should not exceed 0.12. You need to keep these values in mind when we start discussing the arrhythmias. Now, what happens here is atrial repolarization is hidden within the QRS. You don't see a wave specifically for the atrial repolarization, but that does not mean it's not happening. It is, but it's just hidden within this place, but it does happen. Now, we're gonna dive deep about why the QRS complex is forming the way it is, and we're gonna use the vector analogy that we just learned a while ago. So the septum is gonna depolarize first via the bundle branches. We're gonna come back to it. We're still on the QRS right now. We're seeing how the QRS complex is forming. So the septum is going to depolarize first via the bundle branches. The vector is going to point towards the left ventricle side. So this is our vector. Now, we're going to have projections on lead 1, lead 2, and lead 3. And we're going to see that all of them, if you can notice the arrows, all of them are going towards the positive side. What does that mean? You're going to have positive deflections. Hence, you're going to start drawing. It's going to go positive. That's how your wave's starting, because all these projections, after we used our vector and made the perpendicular lines and saw the arrow, yes, lead 2 will be very positive. That is why you can see that the amplitude of lead 2 compared to lead 1 and lead 3 is larger, since the arrow is longer. So this is the starting of septal depolarization, and this forms the beginning of the QRS complex. Now, as the depolarization will spread, the vector will grow longer. And what will happen? It will still point towards the same side, but it's longer. Now we're going to look again. And the arrows got bigger. So the wave is just going to continue and get bigger. So you're still on your same R wave, but it's getting bigger. And the projections are all positive still. All of them, the arrowheads are coming to the positive. So we're still positive. Now, let's see what happens when there is late ventricular depolarization. What happens is that all of this beige area, this got depolarized, but this area is still left because the ventriculars are bigger. So this area is not depolarized yet. So the vector is going to change its direction and it's going to point there. What will this do is that it's going to change the orientation in the vector diagram, and we'll have to look at the leads again to see what's happening. So if this is our vector, the arrowhead here is positive for lead 1, but for lead 3 and for lead 2, it changed to a negative. That's why you're going to see the negative deflections and not for lead 1, because for lead 1, it's still in a positive. But for lead 2 and for lead 3, it became a negative. So you're going to start seeing the negative deflections of the QRS complex. Okay, so yes, this is the S wave. Now, end of depolarization, what's going to happen is that all the ventricles are fully depolarized. There's no potential difference. As a result, the vector will disappear. So it's no longer an arrow. What's going to happen? The ECG will return to the baseline. We mentioned before, when there is no potential difference, nothing will happen. What happens? It comes back to the baseline. This is your QRS complex. Now, you might be wondering, where is the Q wave? Sometimes the Q wave is not there. Not everyone has a visible Q wave, and that's okay. But when a Q wave is there, it is negative. And why is that so? So depolarization, as we said, it begins in the septum. As we made the first diagram, our first vector was going like this. So it begins in the septum, but it's sometimes activated by the right and left bundle branches. And the left bundle branches, sometimes they fire slightly before the right. So the wave of depolarization is going like this. So the vector is not really going down. We're not on a U wave right now. We're still on a Q wave from the QRS complex. We're still there. We're here, this part. Okay, so now since the vector is pointing towards the negative side, if you join a perpendicular line and make it, you're going to see that it's more negative than positive. That's why the Q wave is going to be negative and not positive. Does that make sense? This explains why the whole QRS complex is the way it is. Now, our last thing of the of our ECG is our T wave. What does the T wave represent? It represents ventricular repolarization. Again, a question arises. Why is the T wave, why is it negative again? Yes, sure. So first, our vector was pointing downwards, right? When we were calculating for the R, that's why it was a positive deflection. But when we do have a Q, it's negative. So we're trying to find why is it negative. So sometimes what happens is that the left bundle branches, they fire before your right. And as a result, the vector is pointing here. Now, let's say this is our lead 1. This is the positive side of lead 1, and this is your negative side of lead 1. If you make a perpendicular line, which side does the arrowhead point? It's pointing towards the negative. If it points towards the negative, that means you're going to see a negative deflection on your ECG. That's why it's negative. And if you look at all the other leads, it's also going to be negative. Like, let's say here you join it, it's towards the negative. The arrowhead that's going to form is going to be pointing towards negative, not positive. So a negative deflection. Is it clear now? Okay. Now, so we mentioned the T wave is ventricular repolarization. An important question that comes with this, why is the T wave positive? Why is it not a negative deflection? Why is it coming as a positive one? So the reason for that is that an important concept you need to know is that the last cells that depolarize are actually the first ones to repolarize. So depolarization goes from endocardium to epicardium, from inside to out. So it's going from here to here. But when we are repolarizing, we're going from outside to inside. And what's going to happen is that it's going to cause us like negative charges to go. So basically, as you can see, these negative charges, they're going to go. And when negative charges go towards negative charges, it's going to cancel out each other. And as a result, you're going to get a positive deflection. That's why you're going to see a positive deflection on the ECG for a T wave. Is that clear, everyone? Yes. Okay. So before we talk about the intervals, let's just see how we measure stuff on the ECG, like the grid. So each small square, so this small square is representing 0.04 seconds, and each, how do they cancel out? Okay. So you're gonna have, when there is depolarization, this is gonna be positive, right? The inside is gonna be positive. Now when it's getting repolarized, you're gonna have negative charges going from here to here to here to here. It's going towards the negative. So when negative charges are going towards the negative electrode, you're gonna get a positive deflection, because negative negative gives you a positive. Another way to understand if something is moving away from the vector, if it's going here, repolarization away from the positive electrode is giving you a negative, like it gives you that deflection, a positive deflection. That's why. Just focus on this part. Is that clear now? To whoever asked. Hello? Okay, I'm just gonna move forward with it then. So each small square is 0.4 seconds, and each big square, this whole square, is going to be 0.2 seconds. This is for your time. When it comes to your millivolts, the voltage, it's going to be different, but mostly we're just gonna focus on these measurements since you're gonna be using them for calculating later on. Okay. Let's start with our PR interval. So where is our PR interval? It is from here to here. So it is the time of atrial depolarization to ventricular depolarization. Wait, what question was asked? Could you repeat what you asked? Okay, so normal duration is 0.12 to 0.20 seconds, and it includes the conduction through the atria, the AV nodes, the His bundles, as well as the Purkinje fibers. An AV node delay, it allows the ventricles to fill before the contraction. So you're gonna have an AV node delay here, and why do we need that? So that the ventricles can be filled before you have the contraction. You need to know the normal duration, since when we're discussing arrhythmias, you're gonna need to know how much is, if it's more than the certain value, it's not normal. So 0.12 to 0.2 seconds, how do you calculate it? You count the small boxes from the beginning of the P wave to the R wave. Next, we have our QT interval, which is the total time for ventricular depolarization and repolarization. So our QT interval is from here to here. So it's from the start here to here. It is measured from the start of QRS to the end of T wave. The normal duration is 0.35 to 0.44 seconds. You need to memorize the value. Now, the more important values that is more calculation based is your RR interval. So your interval between your two R waves. So it's between the peaks of your consecutive QRS complex. This is used to calculate the heart rate. So you need to make sure that they're consecutive. So there is no something in between them. It's the next one. How do we calculate heart rate? If you're directly using a value, let's say you count the small boxes here. You're gonna count the small boxes and you're gonna multiply them by the time that we said was, you're just gonna count them and divide them by 60. So it's gonna be 60 over, let's say you say there is, I count all the boxes, the total is, let's assume it's 22. So you're multiplied by the small value, which will be 0.04 that we already mentioned before. And you will, as a result, get your heart rate. If you want to do a quicker method when you're in a rush, you can just see that 300 divided by the number of large boxes. So this box, this box, this box, you will just divide them by 300 and it's going to give you an average and you're going to see where it is. Now, a normal heart rate is between 60 to 100 beats per minute. Okay. Now, lastly, we have our segments. We have the PR segment, which is here, and we have our ST segment, which is here. So PR segment, it starts from the end of 60 is because you are calculating in minutes, and right now we're at seconds, so 60 is for that. And 300 is just a way it's a standard value they've calculated, so you can use it for a faster way. It's not the most accurate since it's better to count the small, but if you're just getting an average value, you can just quickly divide by 300. And we're gonna practice this, so you're gonna see how that works. So let's do our PR segment and our ST segment. The PR segment, it starts from the end of the P wave, and it ends at the QRS, at the start of the QRS. It represents the AV node delay. Why did we say we need the AV node delay? So that the ventricles can get filled. The normal dilation, yes, 60. 60, yes, 60. It's just 60, so you're gonna get beats per minute. So you're gonna just use 60. Yes. Okay. And it's normally flat. Segments are supposed to be flat. If they're not flat, that indicate there's some problem. So if your ST segment or your PR segment, it's elevated or it's low, that means something's wrong. Now, ST segment, it starts from the end of your QRS and till the start of your T wave. At this point, the ventricles are fully depolarized. That's why it's the plateau phase of your AP, like your action potentials, the ventricular action potentials. And the normal duration is 0.08 to 0.12. And once again, they're supposed to be flat. They can be elevated and like depressed, but that would indicate problems. Now, a quick checkpoint. A 70-year-old woman had an ECG at her annual checkup. Use her lead 2 reporting below to answer. What's her heart rate? So I want all of you to calculate. I can zoom in so you can see better. Okay, I got one. 75. Okay, 75. Okay. Let's count them together so that we can calculate. So you have 5 boxes here, you have 10, so 5 plus 5, 10, then you got 15. And then you can add 16, 17, 18, 19, 20, 21. And it's kind of a half of this one and half of this one, so we can go with a 22. So we get our calculator, we'd go 60, whereas divided by 22 into 0.04, since we said each small box is 0.04. So you're getting 68, which rounds up to a 70. So you can calculate 70. So everyone who calculated 70 is right. How did you guys get a 75? What values did you use? Or did you use the 300 method? Maybe it's not as accurate. Okay, yes, the 300. So when it comes to values where they're very close to each other, it's better to use the 61 since it's going to give you a better answer. But you can use that for like general guessing stuff, the other one. Now, a 50-year-old woman complains of shortness of breath on exertion. An electrocardiogram is ordered and her lead 1 trace is shown. Which of the following wave segments or intervals on her ECG trace is outside the normal range? So what seems abnormal to you? Yes, perfect, everyone, perfect. It's PR interval. As you can see, this whole interval is elongated. You don't even need to calculate. You can just tell it's so elongated. Something's wrong. Now, what is the best estimate of duration of the PR segment from this ECG tracing? I'm going to zoom in a bit so you can see. Mind you, it's the PR segment, not the interval. So be mindful of that. Can I have a values? Yes, B. Yes, it's B. So basically, we're going to have 2 small boxes here. So 0.04 into 2, which will give you 0.08. That is giving you B. Is that clear to everyone? All of these questions and everything so far. Yes, 0.04 into 2, yes. So 0.08, yes, that's how you're gonna get it. Is everything clear? Okay.
Yes.
We have one more question. The cell-to-cell conduction of a wave of depolarization through the atrioventricular nodal cells of the heart occurs during which segment or interval of the electrocardiogram trace? Are you sure? Whoever said C, are you sure? It says segment or interval, so think about that. B, yeah, the answer is B. So it's basically through this interval. So it's by the PR interval where you're gonna have the depolarization of the atrioventricular cells. So you just need to focus on the question and what they're asking. Is that clear, everyone? The 60 method? Wait, is that a new question or is that old? To repeat the 60? Because we're gonna start something else. Okay, now we're gonna quickly go over cardiac axis deviations. I noticed this wasn't, why not one? Since they ask if it's a segment or interval, not a wave, so we're gonna take it as the whole thing. It's just the wording of the question. One is the SA node, yes, also. So one is basically the P wave, which is going to be the SA node firing, causing the atrial depolarization. The wave itself is not off the SA node, it's off the P. The delay is off the AV node, yes. Whoever is answering correct. Okay, cardiac axis deviations. So I think you guys took this in your lab, but we're just going to quickly mention them since there's just two main points. So the normal axis in your thing is going to be from -30 to +90. And these are all your leads. So we already know lead 1, we already know lead 2, we already know lead 3. We use them for our the vector analysis. We already use the same diagram. We only added AVL, AVR, and AVF. So F towards the foot, so it's here, AVR right, and AVL left, so left side. Now, the normal axis is from -30 from AVL to +90 AVF. So you need to know that if anything is outside this normal axis, let's say you have a vector that's coming here or here, that means something's wrong. So either you have right axis deviation, left axis deviation, or extreme axis deviation. For now, we're just going to focus on left axis deviation and right axis deviation. So in left axis deviation, the main vector, it points up and left. So if you think about it, the arrow is going to be somewhere here in this area. Hence, it's a left axis deviation. So how will you see that on the leads? Your lead 1 is going to be positive, your lead 2 is going to be positive, and your lead 3 is going to be negative. What is a common cause for this? Why do we get left axis deviation? Left ventricular hypertrophy. We also have right axis deviation. So your arrow is going to be somewhere here in this right axis area. Now, what happens there is that your lead 1 is negative, lead 2 is negative, and lead 3 is positive. So it's what causes it? Right ventricular hypertrophy. When you get a question, you're going to see, let's say, 3 leads and 3 leads. If you see positive, positive, negative, that means left axis. If you see negative, negative, positive, that means right axis. There are other ways to determine this using like AVF and that, but I think you didn't go into detail, so we will not mention that. Now, checkpoint. What is the most likely axis from the ECG traced? What? I'm sorry, you did not get that? Okay, let me just the left axis one. Let me just quickly tell you here. So this is your normal axis. Anything, if your vector falls anywhere outside this, that means there is a problem. So you're gonna, if it's somewhere here, from this area to this area, that means there's gonna be left axis deviation. How are you gonna see this on the ECG? For your lead 1, it's going to be a positive deflection. For lead 2, it's also going to be a positive deflection. And for lead 3, it's going to be a negative. So when you see this 3 of them together, a positive, positive, negative, it's a left axis deviation. But when there is a right axis deviation, your arrow is going to be somewhere here. How is that going to show? You're going to have a negative lead 1, a negative lead 2. 1 + 2 + 3 is left. What? Lead 1 positive, lead 2 positive, and lead 3 negative is left. And lead 1 negative, lead 2 negative. I don't really get what you're trying to say with 1, 2 negative, 3 positive. You see where the QRS is. If you see this one is negative, and this one is also negative, but this one is going to be like positive, right? So you can kind of tell where it is going. So if that's what you're trying to ask. So just memorize this. So whenever you see this, you're going to have to guess which axis we are. And for that, we have a checkpoint now. So what is the most likely axis from Yes, so if whoever said lead 1 is positive, lead 2 is positive, and lead 3 is negative, that means it's a left axis. Are you trying to say it's the other way? I'm confused. Okay, what is the most likely axis from the ECG traced? Left. Yes, it's left. Perfect. So you're going to see positive, positive, negative. That means it's a left axis deviation. Extreme, they did not go into details for you, so I'm not going to mention it. So no need to know that. Now we're going to start bigger bulk of our session, which is cardiac arrhythmias. So what are cardiac arrhythmias? Arrhythmias is abnormal rhythms of the heart due to issues in the heart's electrical conduction system. So when something goes wrong in the heart, we're trying to figure out what happens on the ECG. Your main focus should not be what the disease is or how to treat it or stuff like that. Your main focus is how it's going to come up on the ECG. So things that could cause cardiac arrhythmia, you could have an abnormal pacemaker, rhythmicity. So it could not fire fast enough or slow enough. So you could have tachycardia, bradycardia, stuff like that. The shift of the pacemaker. So SA node is no longer your main pacemaker. Blocks in the conduction pathway. So any pathway in the whole pathway we mentioned in the beginning, it starts from the SA node, then the atriums, then the AV node. Any blocks in the pathway would also cause a problem. So abnormal pathways are spontaneous impulses, which are fibrillations. We're going to come to them. Okay, let's start with abnormal sinus rhythms. So the two main ones are tachycardia and bradycardia. So tachy is fast heart rate. So what's going to happen? How are you going to see? Just by looking at it, what do you think is happening? Okay. So it's going to be faster. That means the RR interval is getting smaller. So your heart rate is going to increase. We said your RR will be shorter. So your heart rate is going to be more than 100 beats. We said the normal is 60 to 100. So it's going to increase. And what is happening? There's increased SA node metabolism. So there's sympathetic activation. So let's say there's blood loss or you're exercising. Everything's going to be normal. You're going to have a normal PQRST. It's going to be narrow. It's going to have a normal length. The P wave is going to be followed by a QRS, and the T wave, it's going to be normal. Yes, if you can say if it's less than 3 boxes, it's going to be tachycardic. Now, for bradycardia, it's the opposite. So it's a slower heart rate. So your heart rate is going to be less than 60. The RR interval is increasing. What is the causes of this? You can have high vagal tones, like that's common in athletes, so it's normal for them. And you could have carotid sinus syndrome and normal PQRST shape, but the RR interval is going to be prolonged. Now, if your vagal shock happens when there is intense vagal stimulation and it can stop the heart. So let's say it keeps on going, it could stop the heart for a bit and you could get a vagal shock. But normally this is just very simple. You can just look at the R intervals and you can use the 300 method and quickly calculate and you'll be fine. Now, another abnormal rhythm is sinus arrhythmia. So sinus arrhythmia is the heart rate that fluctuates when you breathe. So with respiration. So heart rate when you breathe in versus when you breathe out is different. And what happens? It's the spillover of signals from the medullary respiratory center to the vasomotor center. So the heart rate, can you see here? This is your inhalation. It's more tachy. So it's heart rate increased. And when you're breathing out, it's brady. So the heart rate decreased. So this is normal. And when you have deep respiration, it gets more pronounced. So here's normal respiration, and this is deep. So you can see it got more pronounced. So this is normal. This is just when you breathe. Now we're going to start heart blocks. The first one is an SA node blocks. So what happens is the SA node impulse is blocked before it reaches the atria. What are you going to see on the ECG? You're going to see that there are no more P waves and there's going to be a drop beat. There was supposed to be something here, but there is nothing here. So that means there's a drop. Even here, there was supposed to be something, but there is nothing. That's a drop beat. You don't see any P. If you don't see any P waves at all, that means it's a complete block of the SA node. Is that clear? This is the first one. So just remember, a drop beat, we did not mention any intervals or anything. We just mentioned P wave. Now, we have heart blocks that are AV node blocks. The first one, okay, where exactly do we look in the graph? can you see that this gap after this much, there was supposed to be something here, but there is nothing. That means there's a dropped beat. There was supposed to be something. Even here, there's supposed to be something, but there's nothing. That means there is a drop beat. Here, we can still see a P wave, a bit of it. That means it's not a complete block. When there's a complete SA node block, you will not even see your P wave at all. Yes, the whole thing is not there. P, Q, R, S, T, the whole ECG, the whole beat drop, there's nothing. So you're gonna see like this empty space. It looks like there's supposed to be something there, and it's not. Okay, now we're moving on to your AV node blocks. So AV node blocks occurs when electrical impulses between the atria and the ventricle are impaired. So the main causes could be ischemia, so there's reduced blood flow, and that will damage the AV bundle. There could be compression from a scar tissue or calcified deposits that are pressing on it. So if something's pressing on it, it could block it. And if there's inflammation, that could inflame the AV node and it could block. And if there's a vagal overstimulation, like there's extreme activity of the vagus nerve, then it could slow or block conduction. So these are just the reasons. The main thing you need to focus on is how you're going to see the different AV node blocks on the ECG. So the AV node block, the incomplete ones are the first degree and the second degree. Let's start with first degree. So on the ECG, you're going to see a prolonged PR interval. I mentioned you need to memorize the values before, and this is for here so that you can know what's normal and what's not normal. It's going to be more than 0.2 seconds. That means that it's prolonged, and that is a first degree block. But every P wave is still followed by a QRS complex. Like this is still there. There's no drop beat or anything. It's just prolonged. And it's just prolonged everywhere. So it's a consecutive prolongedness. Now, second degree AV blocks, we have two types in that. We have type 1, Mobitz, I think, and type 2, Mobit type 2. What happened is that the PR interval in type 1, the PR interval, it keeps on getting longer and longer, and then you get a drop QRS. So the whole beat dropped. There is nothing. They were supposed to be here, but nothing happened. But before that, you're going to have a prolonging. So it's going to get longer and longer, and then it's going to be a drop. For type 2, the PR interval, it's going to stay constant. This is not getting prolonged. It's the same. But you're going to have a drop QRS out of nowhere. Is that clear? This is the difference between the two. So for type 1, there is a prolonging in the PR intervals. For type 2, there is no prolonging. Both of them have a dropped QRS. Now we have AV node block, which is the complete block, which is third degree AV block. So what happens? It's the complete dissociation between the atria and ventricle. So no impulses are passing through the AV node. What's going to happen is that they're both going to have their own rate. So there's going to be an atrial rate and there's going to be a ventricular rate. Can someone figure out how we calculated these values? By using the heart rate method before, if you could. Is that doable for you guys to calculate this? How are we finding our atrial rate? Yes, you're gonna go from P to P, and from P to P, you're gonna find your atrial rate. And then you're gonna throw from here to here, and you're gonna find your ventricular escape rate. So they're both, since there's a block between the two, they're both having their own rates. So you're gonna see you're not gonna see the normal ECG with the PQRST. You're just gonna see two waves. You can calculate. We can just use the big blocks method. So we have 1, 2, 3, 4, 5. Sometimes appear. It's not really a QRS, but yes, it is. Where would you define the T wave? So it's not connected. So they're very disconnected from each other. They're gonna be beating and they're gonna have their own rates because the connection between them has been blocked completely. So yes, the ventricles have their own pumping rate and the atriums will be pumping. Yes, the P waves are sometimes alone because if you can see, the atrial rate is faster compared to the ventricular rate. That means it makes sense. The ventricles rate is slower. And there in type 2, if you're asking, you're gonna have the same thing, but it's not getting prolonged. So the PR interval is not getting prolonged, and then there's a drop in the QRS. Okay. Now we're going to move on to bundle branch blocks. So what's happening is that the blockage in the left or the right bundle branches. So what's going to happen in the ECG? You're going to have a wide QRS. This is not normal. Normally it is tighter. This is a very wide compared to the normal. So it's going to be more than 0.12 seconds. We can have two types. We can have a right bundle block or a left bundle block. Both of them you can see on one lead and then just memorize for the other lead that it's the opposite. So we're gonna, let's say, focus on the V1 lead. It's gonna have, for a left bundle block, we're gonna have a V-shaped. So for V1 in left bundle block, we have a V-shape. And for V1 in right bundle block, we have an M shape. If the first one is a V shape, the second one is going to be an M shape in V6. And if this one we said is an M shape, it's going to be a V shaped in the V6. So you can just memorize the mnemonic. That is, William is bad for left bundle block. First one is a V and then it's an M. And for right bundle block, it's Morrow. So M and then a V. So why does this happen? Because one ventricular depolarizes slowly through the muscle cells instead of the fast Purkinje system. That's why the QRS complex, it got wide. Since it's not the fast speed, like we mentioned, the speed of conduction, Purkinje fibers were first, then the atria, and then we had the ventricles. So ventricles are slower. That's why it's going to be wider. Now we have incomplete intraventricular block. What happens is there's a block in the peripheral Purkinje fibers. You're going to see a pattern. You're going to see normal, abnormal, normal, abnormal QRS complex. So this one's normal, this one's abnormal, this one's normal, this one's abnormal. This could be caused by ischemia or myocarditis. Now, what is happening? So for the QRS, you're going to have a narrow QRS and then abnormal beat, which is a wide QRS due to slow cell-to-cell conduction. And then you're going to have, for voltage, what's going to happen is that it's going to decrease, and this one's the normal one, and then it's going to decrease. Clear this part, sorry. So the normal beat, you're going to have a normal voltage, and the abnormal beat, your voltage also decreases, and your QRS is normal, and then it gets wider. So this is an incomplete intraventricular block. That's why. So when you see this pattern, which is abnormal, normal, like normal, abnormal, normal, abnormal, just know it's an incomplete intraventricular block. Now, a quick checkpoint. A man had a myocardial infarction at age 55 years. He is now 63 years old. Used the standard limb lead one tracing on his ECG shown above to answer this question. What is his current diagnosis? Okay. Yes. Okay, I'm gonna wait for everyone. Okay, most of you got it right. The answer is a sinus tachycardia. So if you look at, let's just take one of them. Everything is normal. We have a P wave. We have normal QRS. It's narrow. It's not wide. There is no abnormal, normal thing. Everything's normal. This rhythm is normal. And then we have a normal T wave. So everything's normal. The only thing that's not is that these are closer. So if you calculate them, you're going to find out that there is tachycardia. So we can just use 300 divided by 2, which would give you like too big, 150. So it's tachycardic. You can just know for sure. Now, second question. A patient with an inferior MI develops a stable bradycardia of 50 per minute. The cardiologist orders an ECG to evaluate whether there is a sinus node dysfunction or an atrioventricular conduction disturbance. The diagnosis of first degree heart block is made in which of the following cases? So what is the thing that you notice when a first degree AV block? Yes, you look at the PR intervals of the ECG. For first degree, you're going to look at the PR intervals. Perfect. A 55-year-old man comes to his physician for a follow-up visit after being hospitalized 2 weeks earlier for an inferior wall myocardial infarction. The patient has a history of coronary artery disease. His ECG is shown in the figure. What pathology does the ECG represent? Okay. So now I'm going to ask why. Why not like type 1 or why? So B. Yes, it is type 2. No, actually, we're going to see this and we're going to see this and we're going to see this. It's getting prolonged and then it's going to drop So if it's, what are you saying? Sorry. So it's type 2 because you're gonna have, it's not type 2 actually, guys, it's type 1 because your PR interval is getting prolonged and prolonged and prolonged, and then there is a drop. So it's type 1. Does that make sense? If you want me to zoom in on the image, you can kind of notice from here, this interval keeps getting longer and longer and longer, and then we're gonna have a dropped one. So it's type 1. Is that clear? It does, but when you have the picture in person, it's gonna be P waves. I feel like they are merged with the T waves. It's not on great image quality. So you can, when you see the exam question, you're gonna see prolonged waves, which the question was, it's supposed to get prolonged and drop. That is a type 1. Okay, now we're gonna move on to premature contractions. So it's an early heartbeat, which is originating from an ectopic focus outside the SA node. So basically, your pacemaker is no longer the SA node. The heartbeat is gonna come from somewhere else. Causes could be ischemia or type 1 and type 2. Yes, I can. Okay, so we're on second degree. And we're gonna talk about type 1 and type 2. So we're gonna focus on the PR intervals. For type 1, you're gonna see this segment before the QRS, it's gonna get longer. And for type 2, it's gonna stay the same. It's consistent, it's not changing. But both of them are gonna have a dropped QRS later. So just the difference for type 1 and type 2 is that the PR interval is lengthening for the first one. And for the second one, it's constant. Is that clear now? In the exam, you're gonna, in the image, if when I saw it in my iPad, wait, because you can't even tell where the T wave is here, but you like maybe compare from here and then compare it here. Do you see the difference now? That it's a bit longer. Okay, it's a very faint, that's why. Okay, but if it was the same, let's say this one and this one was the same, then it was a type 2, then it's type 2. Okay, so premature, let's come back to that. We have premature atrial contractions, which are early abnormal P waves, which are often followed by a compensatory pause. So this is your premature beat, and because it's premature, so it happened before time, there is a pause afterwards. So this is your pause, this area. Oh, this area is your pause because it's a premature beat. So for this one, the origin of the beat is near the AV node, and that's why you're also gonna have a shortened PR interval. Like this one is very short. So for premature atrial contractions, you're gonna have a premature wave, and it's gonna be followed, you're gonna have a shortened PR interval as well as a compensatory pause after your premature beat. Is that clear? Okay. Then we have junctional contraction, where you're going to have an early QRS. Why the pause? So as we said, it's premature. So premature means it was before time. Does that make sense? The word premature, before, it happened before. So if something happened before time, there's obviously going to be a pause before the next normal thing. The next one's going to be normal. That's why. Now we have junctional contractions, which are, you're going to have early QRS, inverted or absent P waves. So here, from this diagram, you can decode the inverted P waves. Okay, so when you see an inverted P wave, it's a junctional or AV nodal contraction. So yes. Now we have an premature ventricular contraction. So it beats once, then beats twice. See, this one was normal and normal, but this one was premature. That's why there was a pause, and then it's normal. Okay, yeah, it came early, it's premature. For the junctional contraction, you're gonna have early QRS and inverted or absent. In this diagram specifically, we're just gonna look at the inverted P wave. So when the first wave before the QRS is inverted, that means it is a junctional or AV nodal contraction. So now when it's like AV nodal contraction, it does not mean that the AV node is contracting. It basically means the AV node is gonna fire the action potentials, and as a result, the muscles will contract, and it's gonna go both to the atriums and to the ventricles. That's why you can sometimes have it absent, and sometimes it's inverted. That's why, because it's going both to the atrium and the ventricles. Does that make sense? Okay. Now we have premature ventricular contraction. It is wide. As you can see, it's very weirdly shaped. There is no bizarre QRS. There is no preceding P waves. You don't really see much of a P wave. It's kind of there, but it's not really. And the T wave is inverted. So here, your T wave is inverted. For junctional contraction, your P wave was inverted, and here, your T wave is inverted. So remember this. For premature ventricular, T wave is inverted. For AV nodal contraction, it is your P wave. Clear? Okay. Now we're going to talk about paroxysmal tachycardia. So paroxysmal just means it's very random. When is the T wave negative? The T wave is inverted when you have a premature ventricular contraction. So your ventricular is contracting prematurely. Okay. Now we're going to talk about paroxysmal tachycardia. So paroxysmal basically means that you don't know when it's starting. It's very like random. When it starts, when it ends, you don't know. So it's sudden episodes of rapid heart rate that start and stop abruptly. Like you have no idea when it's going to happen. So here we're going to focus on the supraventricular tachycardias, the SVTs. There are two of them. There's atrial paroxysmal tachycardia and AV nodal paroxysmal tachycardia. So what is it caused by? It's caused by re-intract circuit creating a new rapid pacemaker, and it usually is benign unless it persists. Like usually it's not that serious until it's there for a while. We're going to talk about the re-intract circuits. This is the circus currents. We're going to cover them later with ventricular fibrillation. Okay, so in atrial paroxysmal tachycardia, what's going to happen is that, can you notice suddenly from here to here, there's a gap, something changed. It's got tachycardic, as the name says, so the heart rate increased, the RR intervals decreased, and the P wave is often, it's buried in the preceding like T wave. So you can't really tell if this is a P wave or if this is a T wave. You cannot tell, they're merged kind of. So that's how you're going to know. And for AV nodal paroxysmal tachycardia, the rate is 150 to 250. I'm not sure if you need to know, but you're going to see the tachycardia. Just know that for AV nodal, the rate is more. So it's 150 to 250. It's the most common type of tachycardia in adults. The ECG, you're going to see no visible P waves at all. Like here, you cannot even tell what it is. It's just a bump. And there's only rapid, it's rapid. There's narrow QRST complexes. They're very narrow. So this is your whole QRST complex. So this is the difference between the two. These are both supraventricular tachycardias. As the name suggests, tachycardia, faster rates. And the more common one is the AV nodal. Now we have ventricular paroxysmal tachycardia. This one is serious, and it's a more serious life-threatening arrhythmia. Now, what is it? It's a run of 3 or more consecutive PVCs. We mentioned PVCs somewhere. Does anyone know what they are? Anyone recall? We just mentioned it. Yes, the premature ventricular contractions. And what did we say is going to happen when we have premature ventricular contractions? Anyone? You're going to have like inverted T waves. Yes, so you're going to see that here. So this part is your ventricular paroxysmal tachycardia. It's one of like 3 or more consecutive PVCs. So you see the inverted T waves. The QRS, there are wide, there is no preceding P waves, and the T waves are inverted. Why is this dangerous? So it can often cause like ischemia damage to the ventricles. And one of the more bigger reasons is that it can lead to ventricular fibrillation, which is a very lethal condition. You need like 1 to 3 minutes, you need to fix it. Otherwise, it can cause death. It's a very serious, and you need immediate intervention for this. Now, let's come to what we've been talking about, ventricular fibrillation. So can you see there's nothing here that kind of makes sense? You can't tell where a P wave is, where the QRS complex is. You cannot tell anything that's happening. It's so random. So it's the most lethal arrhythmia. It's chaotic, it's uncoordinated ventricular activity. So here in this diagram, can you see these stores? All of them. So in these parts, all of them, they will start making their own, they will make their own, like they will excite themselves, and it's going to be so random that it's not going to cause a contraction or relaxation. So nothing's going to happen. As a result, your cardiac output is going to go to zero. So there's no pumping at all. There's too much happening. It's very irregular. There's no identifiable PQ, RSTT waves. And what is the causes of this? Ischemia, electrical shock, and re-entry circuits, which we're going to talk about. You need to immediately do a defibrillation. So like you're going to pump the heart with electrical, with like or a CPR. You need to do something, otherwise it's deadly. Now, we've been mentioning the circus movements. We've been mentioning them a lot. What are they? So this is the basis for ventricular fibrillation and a lot of other arrhythmias as well. So basically, what are the requirements? You can have a long pathway, which is when your heart is dilated. So like there is more mass, like there's going to be more stuff. So a longer pathway. A slow conduction, which could be because of ischemia or hypokalemia, or a shorter refractory period. So you can have this from drugs like epinephrine. So what happens is that impulse circulates continuously, re-exciting the heart tissue and causing rapid, like chaotic contractions. So this is the normal pathway here. It's supposed to follow the whole circle, like it's going normally. Everything is normal. Now, what happens in the long pathway is that this one, which is the absolute refractory period, then we have this one, which is the relative refractory, and this one is the area that is repolarized and ready for depolarization. Now, let's say there is an impulse. When it's a strong enough impulse, it's going to affect, let's say, this area. As a result, it's going to cause an action potential and it's going to contract. If a strong enough stimulus comes and affects the relative refractory period, it's also going to cause an action potential and contraction. So can you tell it's not it's all of the things are happening at once. It's not coordinated. But however, if a strong enough stimulus comes and attacks at the absolute refractory, nothing's going to happen. So it's basically too many impulses that are continuously re-exciting the heart tissue, and it's causing rapid contractions. And because these contractions are so rapid and random, it's not pumping, the heart's not pumping properly. So it's the cardiac output is zero at the end. Why it is the normal? It's just the way it is. This one's a longer pathway, so it has a relative refractory. Here, it's just the wave is going from depolarization and it's just depolarizing. The action potentials is going. That's why it's the circus movement. There's three of them. When there's the three of them, that means there is a circus movement. And that's how you will have the ventricular fibrillation. Is that clear, everyone? Okay, now we're going to talk about atrial fibrillation and flutter. So these are two very different things. Let's start by fibrillation. Can you repeat this? Okay. So we have circuit moments. Why does this chaotic thing? Can you see this? These small dots here, like these ones. All of them are randomly, they're exciting the heart tissue. Can you see there's so many of them? There's not just one. They're all just continuously doing that. Now, normally it should do this. It should have a complete circle. But here in the long pathway, what's happening is that there's an absolute refractory period, there's a relative refractory period, and we also have this normal like area that is waiting to get depolarized. It's repolarized and it's waiting to get depolarized. So when one of these impulses, let's say, comes and hits it and it's strong enough, it's going to excite it and it's going to cause an action potential and the heart will contract. And then one comes and hits here, it's going to contract. And this one, if it comes and hit, it won't because it's the absolute refractory. But at one time, now three things have happening. This thing is happening, this one's happening, and this one's happening. So it's going to get depolarized. Yes, it's not supposed to, but now because it's the impulses are they're constant, like the ventricle is constantly doing impulses, it will, if it's strong enough, it could excite the heart and cause a depolarization, action potential, and contraction. So in one cycle, there is like three different things happening. So it's too much stuff. Okay, atrial fibrillation and flutter. So fibrillation, you're going to see no clear P waves, and you're going to see irregularly irregular QRS complexes. So they are irregular as well as irregular. So this one and this, and they're very like this up and down. Can you see they're not, and then isoelectric, they're not in the straight line. There's like the line is not straight. Some they're going up and down. This amplitude is different. This one, everything's just irregular. Oh. So atrial quiver, it's gonna affect, what this will do is it's only gonna affect to 20 to 30. Yes, voltage, yes. Irregularly irregular. Okay. So is this irregular? Like, is all the intervals between them regular? No. I'm not sure if you can tell. Like, no, right? So that's one irregular. Are all of them at the same point? Like, oh, this line is very, yeah. No. So irregularly irregular. Makes sense? Okay. Now, what will this atrial quiver? It's only going to affect 20 to 30% of the ventricular filling, so not a lot. And this is how it's going to look in the heart. It's similar to the ventricular fibrillation, where there's a lot of different inputs just exciting the muscle. That's why. For atrial flutter, however, there's just one that's going to go around, and it's fast. It's very, like, it's fast. It's going to be from 200 to 350. It's just going like this, like this, like this. That's how it's going to be. And AV block is going to happen. What's going to happen is not going to, you know how the atriums are before the ventricle? It's not going to allow all of them to go to the ventricle. So let's say two of them come, the atrioventricular is only going to allow one of them to go. So the ventricles is only going to get affected by one of the flutters. And sometimes it could be three, so three come and it only allows one of them to go. So the ventricular rate will get slower. And this one is that clear, everyone? Okay. So in atrial fibrillation, what happens is that you have no clear P waves and irregularly irregular QRS. So neither are the RR intervals between them constant, and neither are they all like in the same isoelectric line. They're all different. So they're irregularly irregular. Now, what happens when there is atrial quiver, which is whatever is happening, this thing, when there's too many signals exciting and a lot of contractions, it's only going to affect 20 to 30% of the ventricular filling. So not a lot. It is a lot. Not a lot, actually, 20 to 30%. So the ventriculars are gonna be fine. But for atrial flutter, what's gonna happen is you're gonna have a sawtooth flutter wave. So these are, I think this pattern is called like a sawtooth. So whenever you see this pattern, like this one, that is like a sawtooth waves. And here, instead of multiple different things exciting the atrium, you just have one which will be rotating like this. And it's fast. It's at like 200 to 350 beats per minute. Now, also, this is in the atrial, so the signal has to go to the ventricles. But there is going to be an AV block, like an AV block is often going to be there. And what that means, 2.2:1 and 3:1, is, let's say there is an atrial flutter. If two of them come, it's only going to let one of them go to the ventricles. And if three of them comes, it might just let one. It depends. It's it's up to the atrium. It's like a ratio, but it does not let all of it go to the ventricular. So as a result, what's going to happen does come with an AV block. Yeah, you can have an AV block because of this atrial flutter, yes. Because it's not letting the current pass to the it's not 2 times slower. It's basically like, let's say you have an atrial flutter and there's two of them. So let's say you went to somewhere and two of you came, they're only letting one of you in for now. And that's going to be there, but it's going to slow the ventricular rate. It's fast. The atrial flutter is very fast. It's 200 to 350 beats per minute. It's like fast, fast, fast. Okay. Now we're going to talk about Wolff-Parkinson-White syndrome. It's because there's an accessory pathway bundle of this is like a congenital deformity. So you're going to have a pathway which is going to cause the potential to go from the ventricles to the atrium, from the left ventricle to the left atrium. That's not normal. That is, something's wrong. How are you going to see in the ECG? You're going to, first of all, there's going to be the PR interval is going to be short. And where is our normal Q? It's not there. You're going to have a delta wave instead. So you're going to have this thing, this inclined line. And whenever you see this, this is VPW syndrome. And your QRS is also widened. It's not narrow, it's wide. But the main giveaway for this is your incline. So your delta wave, as soon as you see it, it's VPW syndrome. Is that clear? Okay, now let's talk about long QT syndrome. It's abnormally prolonged ventricular repolarization. Ventricular AP. Yes, basically that's what's happening. It's not supposed to go to the atrium, right? But it is because of the bundle of Kent, which is a congenital deformity. So here it's gonna go like this and this. It's going back. That's not how it's supposed to be. Okay, long QT syndrome is when there's abnormally prolonged ventricular repolarization. And how it's going to show on the ECG, you're going to have prolonged QT intervals on the ECG. So this port is going to be prolonged. It's not supposed to be from here, like this whole part. I don't know how to show you, but it's abnormally prolonged. And the rest is also not normal. Why? Because of channelopathy. So your sodium and potassium channel mutations, and there's going to be imbalances. And this can lead to a specific type of ventricular tachycardia called the Torsades de Pointes, which can cause fainting and sudden death. This is the one where you saw the image where it goes like this, if you've seen that image. It's an image of tachycardia which goes like this. That is your Torsades de Pointes, I guess. So yeah, that's all you need to know about this, is that when you see it, it's gonna have a prolonged QT interval. So all the way from the beginning of the QRS to the T wave, it's gonna be prolonged. So your atrial, your ventricle depolarization, and so it's abnormally long pause, then it should turn. This is the pause, right? This one times 2. And then this is post-pause, and then it got normal. It's tachycardia, which I think is the ventricular tachycardia you can get. Here? Okay. Now let's talk about cardiac arrest. So it's sudden failure of the heart to pump blood effectively due to an electrical problem. It is not a heart attack. This is the difference between a heart attack and a cardiac arrest. A cardiac arrest means something's wrong with the heart's conduction system, like there's an electrical problem. With heart attack, there's a blockage in the arteries, and that's why the heart muscle gets damaged. Let's say your coronary artery is damaged, that means it's a heart attack. But if you have a cardiac arrest, that means there's a malfunction in the heart's electrical system, and it's not pumping the blood effectively. Now, what's the treatment? You do CPR and defibrillation. Now, checkpoint. Which of the following is fatal? Yes, it's ventricular fibrillation. It's the most lethal. If you don't treat it within 1 to 3 minutes, a person can die. Okay, another question. An 80-year-old man has an ECG taken at his local doctor's office, and the diagnosis was atrial fibrillation. Which condition is likely in someone with atrial fibrillation? Okay. Yes, the answer is C. It is an irregular and fast rate of ventricular contraction. So this is what happens in atrial fibrillation as well. Okay, thank you, everyone. If you have any questions, any concept you would want me to explain again, can you explain this question? Okay, sure. So we're gonna go back to atrial fibrillation. Now we're talking about atrial fibrillation. You're gonna have irregular QRS, and because of that, what does that mean? QRS is your ventricular, like your ventricular depolarization. So that means it's irregular and fast of ventricular contraction. Does that make sense? If you look at the graph, okay, yes, okay. Any other questions? Any point you want me to revisit? I can do that and explain. If you have no other questions, you can scan this QR code. Yes, we will be sharing the slides. Um, can you do the heartbeat? 60? The calculating the heartbeat. Is that what you want? Okay, yes, we can go back to that. Let me give you a question and you can try solving it. Wait. Okay. You saw that, but we're gonna ignore that. Okay, so since the values in the options are pretty close together, we're gonna not use the big box method. We're gonna use the smaller one. So we're gonna count each individual small block. So first we can just count the main ones. This is 5, this is 5, this is 5. So they will give you 15. Now we have 16, 17, 18, 19, 20, 21. And if you just mix the two of them, kind of this one and this one, you can make it 22 or like 23 if you count it whole, right? So now we have 23 or 22 small boxes. We're gonna go to our calculator and we have 60. We're gonna take 60 is always gonna be used because we're calculating beats per minute. We're gonna use 60. 60, we're gonna divide it by how many did we say? Let's say we say 22. And we said each small box is equal to 0.04. So 0.04 will give you 68. So our heart rate, or basically our R interval that we used to calculate our heart rate is 68. Which value is the closest to 68? 70. You could, I think, go with 23 and it would give you this exact value. Is that clear now? And just for generally, if you're trying to see if it's tachycardia or bradycardia, you can just use the big method. So 1 big box, 2 big box, 3 big box, and we'll make these both one more. So 4. So you can just go ahead and do 300 divided by 4, which will give you 75. This is more of a like a rough answer for when you're just trying to quickly figure out. Okay, anything else here? Where are we? VPW. Okay. Okay, so VPW, you're just gonna, since it's going back from, so first of all, we're just gonna say, what is it? It's a congenital defect where you're gonna have an extra accessory pathway, which is the bundle of Kent. So your depolarization is going from the left ventricle to back to the atria. So it's going like this back, and it's a whole circle. So it's going between. Now, what happens is that since it's going back, you're not gonna have a very pronounced the first one, the Q1. So it's instead, you're gonna have a delta. And when you have a delta, your PR interval is obviously gonna get narrow, like you're short, because you don't have the wave that's supposed to be here, so you can add it. Does that make sense? So we were asked. Okay. Anything else, anyone? Good. Excellent. Okay, and you can scan the QR code. Thank you. Bye. Oh, the last question, it's irregular and fast rate of ventricular contraction. When you have atrial fibrillation, you're going to have irregular QRS. That means you're going to have irregular and fast rate of ventricular contraction. Is that clear? Okay, perfect. I think soon, inshallah, with the recordings.